Welcome to AETCM. Today we'll be discussing about a middle-aged man who came to ER with complaints of left lower limb pain. So a 47-year-old man was brought to ER with complaints of left lower limb pain since past 20 days. He was admitted in outside hospital and referred for further management. So my initial 10-second assessment was conscious oriented, but he was appeared to be lethargic with some tachypnea. I went to the primary survey. Airway was patent. There was no stridor or any pooling of secretions. There was no signs of any airway obstruction, but actually his airway maintenance was questionable because he was lethargic. He was also slightly tachypnic. Breathing part, his chest had bilateral equal air entry, but there were basic crepitations were present, and respiratory rate was 32 per minute. Saturation was maintained 97% in room air. Circulatory part, he had a heart rate of 52 per minute and blood pressure noted was 110 by 68 millimeters of mercury. Disability part, even though he was lethargic, he was conscious oriented and GCS for full score was noted. So in the primary survey, ABG everything was maintaining. So along with that, I took some primary adjuncts. ABG was taken. It was showing a pH of 7.25 with a PCO of 28.5 and bicarb of 12.2. So he was in significant metabolic acidosis, and along with that, our ABG also has some additional parameters in which the potassium was noted to be 6.8, and GRBS was not to be, glucose was not to be 669, and lactate was 3.3.
Can you tell reasons for acidosis with hyperkalemia?
One thing, acidosis itself can cause hyperkalemia.
Acidosis.
Okay. Secondly, it could be like an acute kidney injury. Secondary to that, renal failure. Then decay can sometimes present with hyperkalemia. Then rhabdomyolysis, and then severe dehydration. Not.
Trauma with increased muscle injury.
Okay, so rhabdomyolysis and with the renal failure. Some types of renal tubular acidosis. There also, not on all types. Some types you can get hyperkalemia with acidosis.
So ABG was showing metabolic acidosis with hyperkalemia and high sugars, and lactate was also elevated with 3.3. Creatinine was noted to be 4.63, but he doesn't have any previous renal disorders. So it looks like an acute kidney injury. Secondary to that, he has developed metabolic acidosis with hyperkalemia, and also glucose was also elevated. But we also had suspicion because we had the sample was taken with multi-prick, so we took a ECG to confirm. ECG was showing a sinus rhythm of 60 beats per minute with prolonged PR and QTC prolongation with tall T waves.
Okay.
So it was showing features of hyperkalemia.
Heart rate?
Heart rate was 52.
And what are the hyperkalemic changes in ECG? Hyperkalemic changes.
Tall T waves, QR prolongation, ST depression,
what are the changes? ST depression is not there.
Sir, it depends upon the
range.
So initially it will become with tall peak waves.
Very tall T waves, universal tall T waves.
Tall T waves will be there, following which there will be PR prolongation and QTC prolongation. Okay. Then there will be QRS widening. Then sine wave, then P wave will start to disappear. Okay. And then the ultimate thing would be
sine
wave.
So all intervals are going to delay. PR, QRS complex, QT, everything is going to delay. Finally it will become a sine. Okay, sine wave pattern will come. Then most important is tall T waves and bradycardia. Okay.
So at this stage, the patient has two issues. One is his tachypnea secondary to early pulmonary edema, and also metabolic acidosis, and also he has got hyperkalemia with high sugars.
So you have a problem here, a life-threatening problem. One is the patient is having a hyperkalemia with ECG changes. Oh, that is the most important problem here. How to tackle this issue? First of all, you have to tackle that issue. Then next is pulmonary edema. Next is renal failure or acidosis. So how to tackle the hyperkalemia part here?
So considering the ECG change, the patient is going into like an impending stage of like sign formation. So we immediately obtain 2 large bar IV cannulas and initially give a bolus of 2 boluses of calcium gluconate. Bolus means 10% 10 ml over 10 minutes was given. 2 ampules were given. And since he had already had high sugars, we were suspecting also possibility of...
not all that enough. Next is what? Calcium gluconate is correct. You have to give any hyperkalemia If there is an ECG change, you have to give calcium gluconate. Next is what? Here, in this condition.
Insulin IV can be given. Then sodium bicarbonate.
Sodium bicarbonate.
Sodium bicarbonate.
This is the one condition where you give sodium bicarbonate. Because all hyperkalemias, sodium bicarbonate is written last. But here, you have to give it as first choice. Why?
Because of metabolic acidosis.
So it's an impending arrest. Arrest is one condition where you need a rapid shift of potassium. That can be done only with sodium bicarbonate. And you are justifying sodium bicarbonate IV here because of he is having severe acidosis. There is another condition where you give
Sodium bicarbonate.
severe acidosis with hyperkalemia is another condition where we give bicarbonate. Okay. So these two conditions are there in this patient: impending arrest and severe acidosis. So both you can give
Sodium bicarbonate.
Otherwise, sodium bicarbonate is not a good choice. Okay. If somebody is having hyperkalemia, it is not required. You give calcium gluconate alone, patient may come back to normal problem. Okay.
So this initially we gave calcium gluconate. Second, actually we gave injection Actrapid IV was given because high sugars with hyperkalemia.
Okay.
And third,
We have started soda bicarbonate.
no, third we gave soda bicarb. Soda bicarb 50 milliequivalents were initially given, and then again 50 was given over 2 hours was started. Then fourth we also gave 40 milligram of Lasix was given, and along with that,
But is there any urine output?
urine output was there. Like it's not like anuria, but he is having reduced urine output since past 5 days. But still urine output is there. So 40 ml Lasix was given, and again we also checked the IBC at this point, but it was like minimally collapsible. It was not completely distinct, not completely collapsible, but minimally. So at this point we didn't give any fluids, but because again after this we put him on NIV. So basically for hyperkalemia we gave calcium gluconate, soda bicarb, Lasix, and also IV insulin because high sugars with hyperkalemia. And since he was IBC was distended, we couldn't give any more fluids, but in view of respiratory distress he was started on NIV. After on reassessment, his vitals he was maintaining, his tachypnea was still persisting but comparatively better. Then hemodynamics, his BP, heart rate, everything was maintaining. So we continue with our secondary assessment. So we took go into the deep history. So basically this is a man who is a non-case of diabetes since a long time, but is not on regular medications. He intermittently on and off misses his doses. He's mainly on OHS. And then again, he had a history of a trivial trauma about 3 weeks back, or 20 days back. He had a history of trivial trauma on the left lower limb, which developed into a pain and swelling. And after that few days, it became like a ulcerating like lesion, and which got him admitted in a nearby hospital. And following that, the infection extended up to his below knee to the whole lower limb, and also some areas have started showing blackish discoloration. And along with that, since the past 5 days, he has been complaining of some reduced urine output and mild shortness of breath. And since all these conditions worsened, the hospital referred to our hospital for further management. So they have been treating him with IV antibiotics and dressings and everything, but was still not improving. So they referred to our hospital. He doesn't have any non-drug allergies or any other previous issues, but he is a chronic alcoholic and a smoker. He regularly consumes both of this since more than 20 years. But he doesn't have any past previous surgical or medical significant history, and his last food intake before coming to hospital was about 8 hours back. There was no any significant events near in a few days which contributed to the current symptoms. So basically, a diabetic person with injury to the left limb which progressed to an ulcer and probably to a necrotizing lesion. Along with that, a reduced urine output in the past 5 days. So our initial early management was done, and in reassessment, again he is actually tachypneic and all that. But considering we also have a point of care machine over here which can do a quick blood test. So our counts were elevated and CRP was more than 230. So we initially started him on IV antibiotics. Before that, we also had a quick clinical examination. Examination wise, his chest again had bilateral crepitations with equal air entry. S1 was heard, abdomen was soft and non-tender, and local examination, redness was extensively present over the whole lower limb with a necrotizing patch over the sole of the foot with some bed gangrene. And considering it's probably a necrotizing fasciitis, we started him on triple antibiotic regime. He was started him on meropenem one time was given as bolus along with vancomycin and clindamycin. These all three antibiotics were given before, after taking the samples of blood cultures. We took 2 aerobic samples of blood cultures, and then also the all routine investigations, including pre-op serology, because he might be requiring a surgical intervention soon. So we took all pre-op and all routine lab investigations and blood cultures. Then start him on IV antibiotics, and after that we gave initial dose of antibiotic, and we shifted to our ICU for further management. So following the initial few hours, he was stabilizing, but again his
What
tachypnea,
is the creatinine clearance in this patient?
creatinine clearance was noted to be around 12.
Okay. So what about initial antibiotic? Initial dose of antibiotic?
The first dose we can give the full dose. Then second doses we have to give according to the creatinine clearance. So he'll be recurring around 500 BD will be his further doses of meropenem. So after coming to ICU, his actually breathing difficulty worsened over time, and also
If you don't see creatinine clearance, what will happen?
thing is actually the drugs we give have a prolonged duration of action because it will take more time to clear, and repeated doses can go on like a overdose like symptoms like.
What overdose can?
The meropenem, it gets metabolized in the kidneys. So if at all it is being a patient has an acute kidney injury, then the
Injury link.
prolonged activity will be there. So
Why we are
There
worried?
is-
See, you are giving meropenem. Your kidney is not good. It will not be removed. It will become double the dose. You are giving 2 gram meropenem IV TID in meningitis. What is the problem? It will not damage the kidney. But what is the problem?
so it had lowest seizure threshold.
It has got drugs like meropenem and all got a higher seizure threshold.
Sure.
So if you give very higher doses, and if the kidney is not working, the dose will become cumulative in the blood, and that sometimes can produce seizure. So it is not a big problem that you are giving a meropenem in the same dose, even in renal failure, without seeing creatinine clearance. Ideally, we have to see creatinine clearance. But some conditions like patient who is having severe sepsis, even if you don't see creatinine clearance and give, nothing will happen to the
Give
patient.
the full dose.
But if the patient is having a higher potency for seizure, then he can develop some complication. Otherwise, normally even if you give slightly higher dose, nothing will happen. But it is not required in a peripheral injury like this. But if the patient is having a severe sepsis, then you can give the same dose. You can give 1 gram TID, no need to go for the creatinine clearance. You can give little higher dose because the amount of sepsis is too high. Okay, so you can give. So many guidelines are there. You can continue the same dose in a patient who is having renal failure. Okay, but if he is having a seizure potential, then better to control the dose. But here this patient, no need to actually control. You can give the same dose.
So after coming to ICU, actually he had in between a drop in his blood pressure. It went to like 80-50 after about 2 hours. So we initially actually gave a fluid challenge of about 300 ml fluid was given, but there was no signs of improvement. We started him on noradrenaline. And after again the BP again came up to around 120, 110 like that. But his breathing difficulty again worsened over time. So we planned him for elective intubation. So he was intubated by rapid sequence intubation using drugs cetabirnate and rocuronium was given, intubated and connected to ventilator. And following again 2 hours later, there was again a sudden drop in blood pressure, even on noradrenaline. At that time, we noted that the monitor was showing a fast heart rate. It was a narrow complex heart, and this narrow complex tachycardia with a rate of around 180, 200 like that. We took a totally ECG, it was showing a fast AF with a narrow complex tachycardia, and considering the sudden
intubation, what was the cardiac rate, heart rate?
Around 92, 99 like that.
Why to end up so much suddenly after intubation?
It was about
Patient developed AF, sir. Post
Why? What could be the reason? You used only atomitate and muscle relaxation without analgesic.
No, Fenta was given.
Fenda was
You
given.
mentioned.
Fenda was
You
given.
didn't mention. Most important thing, the sympathetic stress
Stress response
response
could be
would be
triggering.
abolished. This is what happens many times if you are not adequately giving any analgesic dosage.
Especially 50 Fenda was also given. Since we have some supports, we gave Fenda also. Fenda, etomidate, and rocuronium was given. But after about 2 hours after the intubation only this happened. Sudden
There will be inadequate analgesia. How long the Fenta will act? What is the duration of action?
around 45.
Most important, you have to sublimate. So, or else if you are scared of, put it on the infusion. So that let it go continuously. So once the patient starts the sympathetic stimulation, the problem will arise. Either descend or they will go to brady and arrest.
So, in view of acute onset of AF with instability, we actually opted for synchronous cardioversion. So, he was cardioverted with 150 joules of shock. And by the first shock, he reverted to a normal sinus rhythm with a rate of around 110. But after that, again, we actually maintained him on noradrenaline, but he was maintaining. So, we took a
It is like this. If the AF, sir has told, no, pain relief, if you see the guidelines for AF, you can understand that. If the AF is due to a reason, secondary reason, then DC shock actually deteriorates the patient. Suppose the side, like sir told, it's a sympathetic overdrive due to the pain. Then actually patient deteriorates. That is a guideline for AF. Not all patients who is saying AF, you cannot DC cardiovert. If there is a reason for that, like hypoxia, if the reason, you have to correct the hypoxia. Pain is the reason, and you have to control the pain. Otherwise, it will deteriorate. So we have to be very careful. If you see the guidelines, newer guidelines says that there is a secondary reason for AF. Correct the secondary reason. There, the DC cardioversion is contraindicated. But according to ACLS, it is correct what you told. Any
unstable AF,
DC cardioversion is the first choice. But recent guidelines also you have to see. Okay.
So after cardioversion, we got a sinus rhythm and he was maintaining on this noradrenaline. We took a repeat ABG. It was showing worsening of metabolic acidosis. And the pH has dropped down to 7.11 and the bicarb has come down to 10.2. So considering his high creatinine with this metabolic acidosis is most, and also the initial lab reports came with serum ketones negative. So it could be most probably secondary to a worsening of creatinine. So we opted him for early dialysis. Considering his worsening of metabolic acidosis, and he was dialyzed for about 4 hours in ED, it's ICU itself. And after that, he was again continuing his treatment in ICU. But the main issue in this patient was the left lower limb necrotizing fasciitis. So along parallel to this this thing itself, we arranged for further evaluation with the surgeon, and also we planned and arranged for all the pre-op and pre-anesthesia checkup, and it was planned for procedure the next day early morning. So after dialysis, his labs and everything improved over time, and but still on noradrenaline he was maintaining hemodynamics and on ventilator. The next day early morning he was shifted to OT for debridement, but actually they had to go for below knee amputation considering the severity of his injury. So BK amputation was done, and after that he was again shifted back to the ICU for further management. And hemodynamically he is stable on ventilator and is currently undergoing his treatment.
So meantime, any Doppler was did vascular.
DVT was ruled out, and also vascularity was also checked. We also had an equipment which assessed the like oxygenation in the limb, which was also maintaining. Then, so we had a specific wing in our hospital with podiatric specialists. So they assessed the vascularity before going for the surgery, and it was viable. So they went with the level was finalized depending on the vascularity only. So the repeated inflammatory markers all came down by the next day morning after that. Initially they had there was a rise in CRP and everything, but by the following days it started slowly coming down, and his acidosis also improved. He's also planned for a second round of dialysis because of persisting acidosis, but as compared to the initial arrival, he's overall getting better. So currently the patient is on ventilator. His noradrenaline is being tapered down. His lab parameters has improved, and acidosis and also hyperglycemia is also corrected. Since the initial arrival, he was put on insulin infusion. It was frequently monitored. So the sugars have been controlled. Hyperkalemia is corrected. Metabolic acidosis has been improved after the dialysis. Inflammatory parameters have been improved after the surgery and also by IV antibiotics, early antibiotics. And the cultures reports everything is pending so far.
Atrial fibrillation? How did you manage?
Atrial fibrillation because only of the only one shock was given, and after that there was no recurrence in this thing. Okay. So it could be probably secondary to metabolic acidosis. Okay. So currently all those issues have been sorted out, and the patient is hemodynamically stable.
Talk about necrotizing fasciitis. One of the most important surgical problems in ER. Okay, because we have large number of diabetic patients, especially in Kerala.
So basically, necrotizing fasciitis is basically a series of infections like necrotizing soft tissue infections. It can actually have multiple levels. So a patient coming to our ED with a complaints of left foot infection, it can be like a simple cellulitis, or once it goes deeper, it can be necrotizing early cellulitis. Then it can go to the deeper levels of fasciitis, then it will be necrotizing fasciitis, and the last will be necrotizing myositis. So the patient's initial symptoms will be more like redness and this thing only, but it will, once it start affecting the nerves and all, it will become like paresthesia and loss of sensation. And after some time, the patient will have show signs of systemic toxicity. He will appear toxic. He will have high fever, and other symptoms will be there. Along with that, locally the skin will start appearing blackish in color, so which denotes there is actually local loss of blood supply with necrotizing of the local tissue. And once the male tissue mainly affects the areas which there are low blood supply. Mainly the fascia is affected because the fascia is having much less blood supply compared to the muscle tissues. So as the infection goes deeper, the last area to get affected will be the muscle tissues. So a case coming like this, we have to like approach in a multiple multiple approaches are necessary. One is we have to deal systematically with systemic antibiotics have to be initiated as early as possible, but it is of no use until we manage the source control. The source of the
In a
infection.
case like this, source control is most important than starting antibiotic. What happens to antibiotic when we start like in this patient?
Thing is actually wherever there is pus or this thing, it is
Antibiotic will never
it
enter.
will never reach that area once
It
pus is
only
formed.
controls the systemic infection. It cannot reach there at all. So you have to control it by surgical method.
There have been multiple studies actually where they have been tried to treat necrotizing fasciitis with antibiotics alone. About 100% mortality has been noted in almost all studies. So antibiotics alone can never be a solution for this kind of infection. So source control is the only option. So again, coming to causative agents, usually the cellulitis will be usually by secondary to the local pathogens on the skin surface, like strep or staph will be the common pathogens. But when it comes to necrotizing fasciitis, there could be involvement of anaerobic species. It could be
It is like this. Any acute community acquired infection is gram positive. If you are treating this patient for some 3-4 days, after sometimes it will become anaerobes and gram negative. Okay. That's why in acute infection always it is gram positive. Chronic infection it is always gram negative. And in between the gram or anaerobes also will come to the picture. So in an infection like this, gram positive alone treatment is not sufficient.
So if it was simply a cellulitis, we would have started him on a drug like flucloxacillin would have been sufficient, or any beta-lactam antibodies would have been sufficient. But when it comes to like a necrotizing fasciitis, our plan of treatment should be like on a with an idea we have to cover all these three species, that is gram positive, negative, and anaerobes.
One more thing.
And also
MRSA. Okay. Because anyway gram positive is there. But since he is coming repeatedly to hospitals, it can turn to MRSA.
So the antibiotic regime suggested is actually after taking the blood cultures as early as possible in view of sepsis. The first one will be a carbapenem with a drug which covers the MRSA group, and also clindamycin to cover anaerobe.
Carbapenem will not cover MRSA.
MRSA.
So you have to add something for that.
Carbapenem plus a drug covering MRSA like vancomycin.
Vancomycin.
Plus
linezolid.
linezolid, and again one more drug to cover anaerobes like clindamycin.
Clindamycin is not started for anaerobic coverage.
It has got antitoxin effect.
Antitoxin effect. Meropenem covers anaerobes. Okay, so you no need to add a drug only to cover that. You are adding a drug which can control the toxins, control the production of toxin. So that's why we are adding clindamycin.
So basically, strep and staph have a property of like releasing toxins into the affected area. So which can clindamycin have an effect of antitoxin. So especially necrotizing fasciitis, we increase the dose like to 900 milligram TID is suggested, especially for necrotizing fasciitis. Because usually in other like infections we usually go for 600 BD or TID, but in this case we go for 900 milligram TID mainly for this antitoxin effect. Then carbapenem, we can go for imipenem, meropenem, or ertapenem can be used, and depending on that,
Ertapenem cannot be used in a patient who is having
acute sepsis.
It can be used only in a patient with local infection. That has to be very clear. We should never start ertapenem in a case of sepsis. Okay, it can be used in urinary tract infection. It can be used in cellulitis, everything. Okay, but it is not a good drug for sepsis.
Okay. So meropenem, along with that, we can go for vancomycin or the single solid, again clindamycin. But if suppose we have to look at another drug, we can also go for piprazole daxobactam, which we can go for like 4.5 gram every 8th hourly, or maybe like 3.375 gram every 6th hourly can be used. This is a drug regime. So a patient with necrotizing fasciitis, one is systemic antibiotic regime along with early blood culture to be sent, and along with that we have to manage the systemic hemodynamics, which will require his airway and airway and also his breathing maintenance and also circulatory maintenance. He could be presenting in like a state of sepsis. We have to then support with lots of IV fluids and then anatropic support. And again, initially we have to arrange for every workup to be done for as early debridement and like source control as early as possible. So one thing is clinical approach, one thing is antibiotic therapy, second is hemodynamic management, third is surgical debridement. Along with that,
Ideally, it has to be surgical management first.
antibiotic, and then third is hemodynamic support.
Hemodynamic support, anyway, we are
We are
in
giving-
emergency room. Airway, breathing, circulation will take care. First of all, we have to ask surgeon to intervene and do it, clear the source. Okay. Without that, whatever antibiotic you give, it is not going to work.
Then conditions like SSS, like toxic shock syndrome and all that. There is also a role for intravenous immunoglobulin injection, which can also be like given along with
Immunoglobulin is recommended in gas gangrene.
gas gangrene,
Okay. Not in other conditions.
which can also be tried in those kind of conditions. So mainly we are dealing with, in this case, a patient with a necrotizing soft tissue infection to the level of necrotizing fasciitis. Along with that, he had uncontrolled diabetes, which was not in decay but was like in a very high sugars, like HHS state. Along with that, following which he developed AK with metabolic acidosis and hyperkalemia. He was presented to the hospital. So initial management, we give initial hemodynamic support. Then we corrected the hyperkalemia and hyperglycemia in the initial stages. We also started him on high-grade antibiotics as to cover for necrotizing fasciitis. Early, so we arranged for all the pre-op evaluation along with the consultation with the surgeon for early surgical intervention. Then in view of his like worsening hemodynamics and respiratory parameters, we intubated the patient, started him on inotropic support, and after dialysis, his basic systemic parameters were stabilized. Then the next day morning itself, he was taken up for surgery, and after that his source control was like controlled. Then antibodies started acting better. Then now currently he is recovering from his basic state.
Anything, sir?
Okay, sir.
Okay. Thank you.